Good afternoon, everyone, and thank you for joining us today. My name is Emily Hawk, and I'm the Special Sections Editor here at the Gazette. Before we get started, I'd like to thank ITC Midwest, who is our Iowa Ideas presenting sponsor. This session is also being recorded, and closed captioning access is available. Questions may also be submitted through the Q&A function on your screen. So the sessions you will attend through Iowa Ideas focus on current issues facing Iowans. This session, Bolstering Iowa's Maternal Health System, will explore how state policies have and have not worked to improve outcomes for moms and babies, and what's missing in efforts to bolster Iowa's maternal health system. With me today are 5 panelists who each have a diverse range of expertise on this topic. I'll go ahead and ask them to introduce themselves. And Dr. Radke, would you like to start us off?
Sure. Yeah, thanks, Emily. Hi, everybody. I'm Stephanie Radke. I am an OBGYN. I work at the University of Iowa, where I primarily practice obstetrics, and I spend a little over half of my time focusing on quality improvement, both at the hospital level for University of Iowa, but then a lot of my time is spent supporting Iowa's other birthing hospitals in performing quality improvement activities and simulations and other programs to help address our rising rate of maternal morbidity and mortality. I am also the current chair of Iowa's Maternal Mortality Review Committee.
Thank you. And Dr. Emily Bavers, would you like to go next?
Sure. Hi, I'm Emily Bavers. I'm an obstetrician gynecologist. I practice in Waverly, Iowa at a critical access hospital here. I grew up in rural Iowa, and so it's my privilege to kind of be back in Iowa's maternal healthcare desert providing care, but I have a unique perspective because of that. As an obstetrician gynecologist in rural Iowa, I benefit tremendously from Dr. Radke's work, so thanks, Dr. Radke. I'm involved in policy and advocacy in a number of different ways, including through leadership positions with the Iowa Medical Society and ACOG, as well as through an organization that I became involved with, Iowans for Health Liberty, which is advocating for reproductive freedom in Iowa.
Thanks, Emily. And Sophia, would you like to go next?
Sure. My name is Sophia DeMartino, and I serve as Executive Director of the Black Maternal Health Collective. We're an organization that got started 5 years ago, back in 2019, and our work is dedicated to the goal of ending maternal mortality gaps for women in Iowa.
Thank you. Asada, would you like to go next?
Yeah, so my name is Asato Whirl. I am a scientific and medical illustrator and animator, and I own Legacy Bio Studios. So as an illustrator, my job is to make sure that I'm helping fill that gap of communication between providers and their patients. My emphasis is in diversity and inclusion, as well as patient advocacy.
Thank you. And Rachel, would you like to round us off?
Hi everyone, I'm Rachel Bruns. My pronouns are she, her, and I'm a chapter leader for the International Cesarean Awareness Network of Central Iowa. We are a national organization with about 100 chapters across the world that works to improve maternal child health with a focus specifically on reducing preventable cesareans, supporting cesarean recovery, and advocating for vaginal birth after cesarean, also known as VBAC. In addition to serving as a chapter leader, providing support to Iowa families that are looking for cesarean recovery support and VBAC support, I also serve as a patient advisor on the Iowa Maternal Quality Care Collaborative, which Dr. Radke leads. I also participate in the Maternal Health Coalition led by Iowa ACES 360 and help support a maternal health day at the Capitol in partnership with Postpartum Support International of Iowa and ACES 360 as well.
Excellent. Thank you all for your introductions. So I will just go ahead and dive in. So to frame the discussion, I'd like to start off by sharing this statistic from a 2023 report from March of Dimes, which found that a third of Iowa's 99 counties are considered maternity care deserts. What does it mean to be a maternity care desert? Dr. Radke, do you want to lead that conversation?
Yeah. So March of Dimes has a definition for maternity care deserts that I think has really caught a lot of national attention. And so it's generally what people are referencing when they use that term, but not always. So it's good to just be careful as you're reading different pieces. But theirs is a scale of access, and they're looking at the county level, is there a hospital that has a labor and delivery unit, or is there a birthing center available in that county? So somewhere within a healthcare system to give birth. And then it's looking, if we don't have that, then are there healthcare providers that provide pre and postnatal care in the county? And so there's levels of desert, but in the report and the statistic that you referenced, they're referring to the 33 Iowa counties that do not have any of those services available, meaning there's no hospital that has a labor and delivery unit, and there are no known providers of prenatal care in that county.
Thank you. And Dr. Bavers, do you have anything you'd like to add to that at all?
Well, I agree. The definition that's present in Iowa, particularly, like you said, a third of counties are considered maternal care deserts. We have a lot of counties in the state of Iowa, but really looking at the definition of this and how it transcribes geographically to a map of Iowa, we've got vast swaths of area where, a number of counties are maternal health deserts. So even though Iowa has a lot of small counties, really the impact of maternal care deserts in Iowa is really significant in the regions that are most affected.
Thank you. So I'll just go ahead and dive into my second question here. So what factors are driving changes in the maternity care access that we're seeing in Iowa, especially within those rural areas and among Black, Indigenous, and people of color? Dr. Radke, do you want to start us off with this one again?
Yeah. So I think many people who are following this issue are probably aware that one of the main drivers of our growing number of counties that are designated as deserts is that many small Iowa hospitals are choosing to close their labor and delivery units. And I think that's a really complicated factor. There's not one force that causes all hospitals to close. I think it's really a pretty complex issue, and usually something that is undertaken with a lot of thought at the hospital level. But ultimately, the challenges that are common themes for facilities that end up closing their labor and delivery units, it's financial at the end of the day, and a lot of times that's driven by a low delivery volume. So most of the hospitals that have closed their units, leaving their county as a desert or growing a desert region in the state, are delivering less than 100 babies per year. Or if they're over 100, it's maybe just a little bit over 100. And I think that speaks to a more complex issue around, what's happening in Iowa's rural areas. And, if there aren't babies being born there, it generally suggests that you don't have a robust population of young families and people of reproductive age living in the community. And we know that is a trend in Iowa and in other states of urbanization where not everybody is like Dr. Bavers, where they grow up in a small town and return to their community to live and put down roots and start their family there. So when I think about this issue, I think, yes, there are things that we maybe need at the hospital level. Maybe financial incentives would help hospitals offset financial losses associated with running a low volume unit. Maybe there are strategies, we definitely know there's effective strategies to help recruit providers and nurses to want to work in these areas. But I think ultimately we need to have people who live there that are giving birth to make a unit viable. So I think that's a piece of the conversation that we sometimes don't hear, is it's not necessarily that hospitals with really robust obstetrical service lines are closing. It's that facilities where the volume has been dwindling for years, it's not a vibrant community with lots of young families. And then it kind of culminates in maybe the last remaining provider deciding that this isn't where they want to practice anymore, or they're ready to retire and there's no one to replace them. So I think when we think about how do we reverse these trends, we need to think about, yes, having providers and nurses to work in these places. Yes, we need good reimbursement and maybe even incentives for small hospitals to have maternity services, but we also need to think about, what does Iowa need to do to make our small communities attractive places for people to move to who are growing their families.
Absolutely. Dr. Bavers, do you have anything you'd like to add to that, Sophia, before I get to you?
Yeah, absolutely. I couldn't have said it better myself. Really, this is a question of how do we revitalize our rural communities and make Iowa an appealing place for young people to live, work, and raise their families. And that's such a huge issue that is certainly multifactorial, ranging from, having good economic opportunities to having great public schools. And so these are the reasons that, communities in rural Iowa are growing, is that they do have economic opportunities and great schools. And when we see communities that are not growing, that's where you'll see that there's not perhaps a good resource for maternity care in that community. I would just kind of second that the other thing that trends with the loss of obstetrical units across the state of Iowa is that there also tends to be a loss of access to long-acting and effective contraception. And so as we see maternity care deserts, we also see contraceptive deserts across the state. So those things are related and tend to then affect persons that are already living in perhaps a low economic opportunity environment and then having minimal access to very reliable or long-acting contraception versus places that do have a good amount of economic resources and economic opportunity tend to maintain those services.
For sure. And so, Sophia, what factors are driving changes in maternity access for the BIPOC community? Can you maybe speak to that?
Sure. There's an old saying, when white America catches a cold, Black America catches pneumonia. BIPOC birthing people already experience disparate outcomes. So the closure of those facilities across the states, stagnant reimbursement rates, the challenges that are impacting everyone mean the outcomes for BIPOC individuals that were already bad are worse. Further, the lower rate of BIPOC people in those rural areas means that issues may go unchecked due to those lower numbers of people. It's much harder to identify systemic issues when your population size is much smaller. And it's also really hard to convince people, hey, this is a really important issue to pay attention to. When we started the collective originally, one of the challenges that we faced was people still thinking, oh, well, there's not that many people here. I mean, how many people does that really represent? So when you start to look at percentages and see the issue from that perspective, it looks a little bit different. But when you're in a rural area, it's really, really difficult to impress upon people, hey, no, this is a really important issue here. If there's maybe only 1-2 women in town that they can even think of that this might apply to, or I should say birthing people, excuse me.
Mm-hmm.
Emily, can I add something?
Yeah, absolutely.
I would just want to add to the conversation and build off of what everyone else said, that I think it's important to note that there are other providers outside of the hospital space that are also providing maternity care. In Iowa, we have certified professional midwives and certified nurse midwives that are practicing, currently providing home birth services, which is providing a really critical service in rural Iowa. And we would be remiss not to mention that we should really be expanding access to that type of opportunity and provider in collaboration and integrating that with hospitals to provide seamless integrated care for a lot of rural families. Having access to home birth can help reduce a lot of barriers to prenatal care, which is so critical to ensuring healthy pregnancies and healthy births. And also, we know that access to midwives helps to improve outcomes as well as to narrow racial disparities that Sophia is mentioning as well, and also reduces costs for our Medicaid programs and other payers. Unfortunately, in Iowa, we significantly, in addition to not paying our hospitals enough for maternity care, we also significantly under reimburse midwifery care in the state. Both for certified nurse midwives, but on top of that, pay midwives for home birth at a level that is not sustainable, that we only have 2 home birth providers in the entire state that currently accept Medicaid. They're actually reimbursed worse than doulas by some of our MCOs. So we have graduate level nurses providing 10 plus months of prenatal care in a home birth setting, meeting people where they are in their community, getting reimbursed almost only like $1,000 for that entitled prenatal care and birth care. So we really need to look at strategies that are integrating and collaborating across providers to improve access to care in these communities.
And so before I move on to my next question, Asada, is there anything you'd like to add?
Well, I mean, I think I'm more of like the communication end of things. So whenever
Mhm.
it comes to how are we actually having these conversations and what are we doing in order to actually support these individuals that are in the middle of their pregnancies and they're wanting to have safe births, a big part of my focus and job is to make sure that we're properly providing resources in order to make sure that when you have providers in that area, because if you only have a short period of time in order to have time with these individuals, how can you maximize that opportunity? And so for me, illustrations and animations are our primary focus when we're making sure that we're offering resources for these individuals, especially if you're talking about areas where maybe there's one provider that's actively traveling around in a rural area, checking in on women and seeing how they're doing either during their pregnancy or after their pregnancy as well.
Absolutely. And so I'm interested, so what medical conditions are the main causes of death that we're seeing in pregnant women? And how does the rise in maternity care deserts correlate with the increase that we're seeing in mortality and morbidity rates among pregnant women? Dr. Babers, do you want to start us off with that one?
Sure. One of the main drivers of maternal morbidity and mortality is the increasing prevalence of hypertensive diseases of pregnancy or preeclampsia and eclampsia. This is multifactorial, but part of it pertains to a rising age of childbearing among women. Which is, a rising age at first childbearing is not a bad thing. It usually means that women are maybe more established in their life or have a more secure family situation, but they can also be accompanied then by comorbid health conditions that just occur with aging. There are certainly racial disparities for hypertensive diseases in pregnancy, though that's not, a strict correlation. And so eclampsia and preeclampsia are one of the biggest drivers of maternal morbidity and mortality. However, other things such as hemorrhage at the time of childbearing can be a big driver of maternal morbidity and mortality. This is something that, particularly in rural areas that have a low volume of deliveries, people may not have that muscle memory for how to care for a person with hemorrhage. They may not remember the doses of medications or have easy access to medications. So this is something that both of these are things that the programming that is provided through Dr. Radke and the University of Iowa has helped a lot of our more rural hospitals to develop algorithms and toolkits to be able to very quickly and uniformly care for these patients. Worldwide, infection is a big driver of maternal morbidity and mortality, although here in the United States, access to antibiotics has reduced that. Unfortunately, domestic violence and maternal homicide is actually one of the biggest causes of maternal mortality. This would be any sort of domestic violence or homicide within the first year after delivery. And all of these things in the setting of a maternal health desert are really affected by just inadequate access to prenatal care. When women have to travel further, when they have to take more time off of work to get to appointments, when women have less insurance or less resources to travel to appointments, they tend to get less prenatal care. When they get less prenatal care, whether it be care at home because somebody has come to them or care that they've gone to a hospital, these conditions may not be recognized as quickly as they would if they had adequate prenatal care. And so it's a delayed diagnosis that then can put women at high risk. For example, if you had someone who had not been seen for 2 or 3 weeks in the third trimester and they were not monitoring blood pressures at home, by the time they come to the hospital because they have blurry vision or they have had a stroke, it may be too late to effect a safe delivery for them or have safe treatment for them. And so that's why having good access to routine prenatal care is really a key here, and why the maternal health deserts do such a disservice to our birthing populations in those parts of the state.
And Sophia, I see, has her hand up.
Sorry.
Yeah, please feel free to jump in whenever you'd like.
I just wanted to say, having spent quite a bit of time within the social services realm in Iowa, the other thing to consider is that maternal care isn't just a maternal care desert, right? If we're looking at some of these rural areas, a lot of times there are several services that are harder to access, that are further away, that there's more cost involved in accessing. And that would include things like services related to domestic violence. It would include things related to nutrition access, would include transportation challenges, would include employment opportunities. So there are a lot of factors that go into those rural areas, and why some of those health disparities might be there.
And I just wanted to note to both what Dr. Bavers and Sophia are saying is that while what we're talking today about is maternal health, Iowa was one of only 4 states in the country in 2023 to see an increase in infant mortality. And so all the things that we are talking about, access to prenatal care, directly impacts not only maternal health, but also infant health. We hear the saying a lot, healthy moms, healthy babies. Well, if our mothers are not getting access to prenatal care, then they're going to potentially have issues with the infants as well, their babies. And the top 2 drivers for the reason for that increase in infant mortality was lack of access to prenatal care. So what we're talking about, maternal health access, followed by poverty, which really aligns with those challenges that Sophia was addressing as well.
Mm-hmm. And so, Sophia, this is for you as well, and even Asada, because I know Asada, you work, some of your work has to do directly with helping immigrant populations access prenatal care. But why are we seeing disparities in that prenatal care and higher mortality and morbidity rates among the BIPOC community compared to white women here?
So one of the things that I want to make sure that we note here, because a lot of times when this conversation comes up, there's an automatic response, and that is, oh, well, it must be related to food, it must be related to income, it must be related to all of these different things, right? But the statistics related to Black maternal mortality control for socioeconomic status, it's so extreme, in fact, that a Black woman with a master's degree is more likely to die due to childbirth-related causes than a white woman who didn't graduate from high school. So while those environmental factors, social determinants of health really matter as well, they play a role, but we can't ignore the role of bias in those disparate outcomes for maternal mortality as well. There are misconceptions that are held by people. It's unconscious bias. Sometimes it's systemic factors that are impacting people, but it holds across the board. So I just want to make sure that we address that as part of this conversation too.
Mm-hmm.
Yeah, and as because I'm a medical illustrator, so I'm going to be focusing on this in the focus of communication, which what we have been seeing in a lot of these situations with the provider and BIPOC patients is that there really aren't quality open lines of communication between these 2 groups of people. So when I'm saying quality communication, I am saying that at the beginning, at the foundation, you have to have a common vocabulary. So this common vocabulary is essentially how 2 individuals or 2 groups of people are going to have a conversation with each other with a foundation of, okay, these are the words that we're using. This is what these words mean. And so you ask your questions, I answer them, and we try to make sure that we are having a conversation and understanding each other. Now, when it comes to BIPOC communities and marginalized communities, and especially immigrant communities, you have to also consider trust. So if there's no trust, there's no purpose for the common vocabulary because those patients aren't going to use it. They will not participate in the healthcare. They won't ask questions. And in some extreme cases, they will avoid stepping foot into those offices because they just don't trust the system. So when it comes to trust, we have to go, okay, well, why why do we have such mistrust in these communities? And in all honesty, like we have to focus on history. So historically, when you are talking about the healthcare system and how it has been treating BIPOC communities, marginalized communities, there is a lot of neglect, and historically there has been abuse. And a great example of this is James Marion Sims, who many of us know is considered the father of modern gynecology. Now, in 1845, when this was happening, Sims was developing his systems and his techniques by practicing surgery on Black enslaved women without anesthesia. And his explanation for why he wasn't using anesthesia was, well, Black people don't feel pain the same way as white people. Now, this is horrific, and we know that this isn't an isolated situation. So when you're having situations like this happen over and over again throughout history, and those are the systems and those are the people participating in building these systems, you have these marginalized groups that go, that's not a safe place for me. That's not a place where I can participate. Now, one of the things that Sophia had mentioned is when you have systemic racism, and we can see direct lineage from Sims' behavior to the proceedings of the National Academy of Science found that in 2016, 50% of med trainees believed the myth that Black people, in fact, feel less pain. And they thought it was because Black people have thicker skin or reduced sensitivity in the nerves. Now, this is a myth. We know that's not true. But the fact that this was 2016 and 50% of these students believed that goes to show that the systemic systems do raise into these biases. Now, the thing about it is we're just talking about like one period, like one situation during the period of time of 1845 to 2016. But something to think about is when you have these situations, think of all the people, all the BIPOC individuals that were going in to get assistance when they absolutely needed it, and what kind of negative interactions and experiences they're probably experiencing. That's going to reinforce for these communities that this is not a safe place and this is not a place for you. So then you end up with a culture of healthcare system is not for us. We take care of our own. We have to deal with this with home remedies. And we only go outside of our little circle when we absolutely have to, like life or death kind of situations. Now, when it comes to the healthcare end of things, any progress that the healthcare system has been making over time, things like preventative medicine, the importance of health literacy, groups that are safely comfortable coming into those environments and learning and being a part of that, they benefit from that. And we know that traditionally the people that are going to feel safe in the healthcare system are white individuals. But for the marginalized groups that have not been interacting with the healthcare system, they've been actively avoiding it, they do not get access to that information. So they're not practicing preventative healthcare and preventative medicine, and they're not getting that information in order to build their health literacy. So then you end up with this very large gap that we're trying to ask providers now to say, okay, you have 15 to 30 minutes. I'm requiring you to build a communication line over generations of instability and lack of communication. And you have 30 minutes to build that trust and build that communication vocabulary. And that's kind of a lot to ask somebody to do in just that short amount of time. And from the perspective of a medical illustrator, that is one of the considerable reasons of why we still have a lot of these disparities.
Thank you so much for sharing that. That's obviously a very important part of this conversation. So thank you, Asada. So I want to go ahead and segue into state policies and legislation. So what state policies and legislation have affected maternal health care in Iowa? This can be, both negatively or positively. And Dr. Radke and Dr. Babers, do either of you want to start us off with this question?
Emily, do you want to start?
Sure. There have been some really positive things that our state has tried to do for maternal health care over the last several years. Certainly one of them was the development of our obstetric fellowships, which train family medicine physicians to provide cesarean deliveries and increased obstetric care. This is an important step because in states like Iowa that are rural, a large proportion of deliveries occur by family medicine physicians rather than obstetrician gynecologist trained physicians. And so this does certainly help to improve the safety of deliveries and offer that cesarean service for when it's needed. I think another thing that the state has done that's been really positive, is by expanding access to midwifery in the state and trying to bring additional midwife providers into the care model, and including them in kind of how women can access care. The flip side of that is that unfortunately, anytime there's any sort of delivery, whether it occurs at home or in a hospital, there's inherent risk in that process, both for mom and child. And the state really has not done a lot of investment in the transportation systems across the state to move people from our low resource maternity care deserts to our acute hospitals when there is an emergency. And that's true whether they deliver at home or whether they deliver at a critical access hospital like mine. Medical transport in the state remains one of the biggest barriers to safe maternal and infant care. Another thing that the state has done that is positive just this last session is expanding the length of Medicaid coverage after delivery. There again, the flip side of that is that they decreased the eligibility limits for Medicaid. And so while there is a population of very low resource individuals who will have 12 months of Medicaid coverage after delivery, there's a different population that is maybe not as low resource as them, but not yet high enough resource or in a job that offers insurance coverage itself that will go without coverage or will have to try to pursue coverage in the marketplace, potentially spending, a lot of their income on coverage, which would kind of bring them back to a position of relative poverty. And so this is, there's a lot of kind of good things that have happened as well as some bad things. I will say that, in terms of trying to recruit physicians to the state, our legislature did pass a limit on the non-economic damages that can be gleaned in a medical malpractice suit. And so this does in some ways reduce some of the risk around providing obstetric care for all kinds of obstetric care providers in the state. However, it still is a state that's very difficult to recruit additional providers to because of some of the things like our ban on abortion services after 6 weeks of age. In general, I think that one of the most negative things that our state has done is continue to push forward a 6-week abortion ban. What we know is that abortion bans make childbearing, pregnancy less safe. Even when exceptions are in place, we have seen from our state and other states that they're very difficult to access. And when we have an exception for something like the life of the mother, it's very difficult for physicians to know when that balance is tipped between intervening and when it is appropriate and legal for them to intervene. We've also seen from other states that abortion bans increase rates of peripartum homicide. And so in addition to increasing the risks associated with pregnancy physiologically, abortion bans increase the risks associated with domestic violence. And they increase the number of women who are having unplanned or undesired pregnancies, removing the ability of women and families to time pregnancies for when they feel is best for them, and time pregnancies and growing their family according to their own values and beliefs. And so some positives certainly in our state, but some negatives as well. The last couple things I'll mention is that we don't have access to over-the-counter contraception yet. That has not been a legislative action that has been able to get through our legislature yet. In terms of, one of the earlier things that can help to make a difference for maternal health, I would argue that sex education is very important in the inclusion of comprehensive sex education in our schools. Iowa does have a law that mandates sex education, but it does not mandate any particular curriculum. It can be abstinence-only sex education. It does not have to include information on contraception or safe sex, and students and families can opt out of this. And so I'm a big believer that where we start in terms of establishing health and establishing that healthcare relationship is through early education and early exposure to these ideas. And a more developed and robust sex education curriculum could be a good pathway to that.
Yeah, I think that covers a lot of it. I'll just echo some points that I think we have really specifically experienced. I think it is a challenge to recruit OBGYNs, is what I have experience with trying to recruit, but it's challenging to recruit OBGYNs to our state right now. I think we struggle with that at the university, and we hear that people are struggling with that across the state. I think when people are from Iowa or they've lived here for some period of time, they may be more recruitable. But I think there is a lot of uncertainty in the OBGYN community nationally right now about what it means to practice in a state with abortion restrictions. And people have very legitimate concerns about providing care that they believe to be necessary to save someone's life, and then having those medical decisions that they made be questioned later and potentially to have repercussions from that. In Iowa, it could result in you losing your medical license and being unable to practice and essentially be a career-ending thing. In other states, it could also result in more of like a legal sentence or fines or other very meaningful consequences. So I think it's really important for people to understand that those issues are actually very directly related. And when we talk to people that we are trying to recruit to come join our practice in Iowa City, these are the types of questions that people are asking. They are wondering if this is the place that they would want to practice. And I just don't know that the legislators really considered that sort of far-reaching impact of some of these. And these are not providers that are necessarily intending to have abortion care as part of their practice. They're just wanting to practice obstetrics and gynecology. And they understand that sometimes pregnancies are life-threatening and that these decisions are very complicated. And they want to feel that they are able to provide high-quality medical care without concern.
I will add a few things. Dr. Bavers and Dr. Raggi mentioned a lot of the key things that have happened in the last couple of years at a policy level. A couple of things that I would mention that have been challenges, I think, from a state policy perspective, and just not talking about specific legislation, but thinking about policy from like the administration of the state. One is that as a patient, and I represent and I'm a patient advocate, and my role is it's really hard for patients to find information about cesarean rates and VBAC rates at hospitals and to really understand the type of care that they can expect. Iowa is one of the few states that doesn't publicly make that information available, where other states do publicly make that available. I every year have to go through a public data request and get that information and publish it. I wish that like media sources like the Gazette would do that instead of me having to do that as an average citizen. But really the state should be making that available. And going back to the conversation about disparities, Iowa has a much higher cesarean rate for Black women than white women, almost 4 percentage points higher. And there's no medical reason for that. And a recent study that came out from New Jersey showed that in the same hospital with the same doctor, a patient that is white that has a similar health history as a patient that is Black, the Black patients were 20% more likely to have a C-section. And in those situations, it was oftentimes that the operating room was empty there was a suggestion in the study that there is both a racial bias basis for that and a financial incentive for that as well. And so while that was New Jersey, we can see in our own cesarean rates that higher percentage of C-section rate for Black patients is impacting them and impacting their mortality, morbidity, and outcomes, and just lifelong impact. I've had a prior C-section, and I will always have to live with the complications of that for the rest of my life. It may not be complications that come to fruition for another 30 years, but they're inevitable and potentially there and can impact future pregnancies as well. So the lack of data for citizens in Iowa to navigate and look to see, like, what is the C-section rate at my local hospital? Is that a place that I want to go? There is research on thriving rural hospitals in our country that Iowa hospitals and rural communities could learn from. And a lot of the case studies from those show that thriving rural hospitals are those that respect patient choices and allow their providers to practice in their full scope. So what does that look like here in Iowa? We have a lot of family physicians that I've talked to that they've left obstetrics because hospital administration will not let them practice in full scope. They're not allowed to do VBAC. They're not allowed to deliver vaginal breech births. They're not allowed to provide the respectful patient care that they want to provide to patients. So they stop practicing at those hospitals, and that means patients stop going there as well. So it's interconnected, that providing that respectful care is so important. If we are going to be funding OB fellowships, which I agree is really important and positive, then those hospitals need to actually hire those family physicians, because I also hear from folks that hospitals are saying that they only want to hire OBGYNs. We have family physicians that are interested in being here, but the hospitals are either not hiring them or not allowing them to practice within the full scope of their authority. So that's something that I think is important to note. We can't take at face value what hospital administrators are saying is a financial or workforce issue when they haven't been asked the tough questions around what does that really mean in terms of recruitment and the financial impact of the choices that the hospital administration is making. So I could go on about other opportunities, but I know I'm occupying the time, so I'll pause there.
Thank you, Rachel, for sharing that. Sophia, did you have something you wanted to say?
The only other thing I think I would want to interject, and this is not specifically related to policy, it is related to recruitment. When we think about workplace discrimination, medical establishments are not exempt from that. So when we have an environment where the vast majority of people look one way, and then we have, someone new coming in, how are they treated? What kind of opportunities do they get? Are they trusted to be capable of the work that they've been assigned to do? What kind of an environment are they walking into every day? What are their water cooler conversations like? What is their relationship with their superior? These things are going to apply across the board. We know that Black people who have Black doctors have better outcomes, but what does it look like to recruit? And I can say this is across so many different industries. I've had this conversation for years, whether that be among educators, or any field. But as soon as you start saying, well, we really should probably see some diversity in the room, and the conversation starts going, well, we really want to make sure we get the best people. If we've already limited ourselves in that way, then we're already not getting the best people. So we need to be more inclusive in how we think about hiring and how we think about retention, and how we address that issue as well, if the goal is to have a strong workforce within the medical field that can have good outcomes.
Adding to what
Absolutely.
Sophia is saying about hiring and making sure that we're being inclusive and having diversity in these workplaces, another thing that I have been noticing, because I do work with younger individuals, especially young Black women that want to be in the medical field, often we keep seeing that this constant reinstatement of, well, if you're going to be in this field, you have to be the absolute best. You have to be spectacular. And it makes it very hard. Like the women that I know that are practicing medicine or are practicing in dentistry or as nurses, the amount of grit that these individuals have to have just to get through these programs to be able to be hired, and then that continued grit in order to be practicing is tremendous. And so another thing that we need to be thinking about is, while we're wanting to make sure that we have diversity, we have to make sure that, yes, there is very much inclusivity in it. And we have to make sure that the younger generations that want to be doctors and nurses get to see that as well. But they need to have an example.
For sure. So now that we've laid all of this groundwork, how can we address the issue of maternal health deserts and the rising mortality and morbidity rates in pregnant women, both on the medical side, the legislative side, and even on the community levels? And what resources do we currently have available to do that? And this is open to everyone.
I have a long list, so I'm gonna start, but cut me off so others can chime in. So I will note, I mentioned earlier that I'm part of a maternal health coalition, and last year they were part of pushing forward the postpartum 12-month expansion which was a large coalition of folks that helped get that through. And that coalition is now working on a new initiative that in 2025 will be proposing to the legislator to get an Iowa perinatal psychiatric access program to provide more resources and support to maternity providers on mental health resources for maternal health patients. So that's something that is happening already in 20 other states across the country. And so hopefully Iowa can become the 21st state or one of many other states that makes those resources available, given that mental health is one of the issues impacting especially postpartum women. And that Iowa is not only a maternal health desert, but also a desert in terms of mental health resources. So that's one big issue that I would mention. The other thing that I am a big advocate for is just improving access to midwives across the board. I mentioned earlier the importance of improving midwifery care reimbursement. Iowa is one of the only states that reimburses midwives at 85% of the physician fee for the same work and the same outcomes. And this needs to change. This is a pay parity and workforce issue. If we want to recruit midwives into the state, we need to pay them equitably. And this is also, while we have this is just a gender issue and a pay parity issue for midwives. And I mentioned also the pay issues for home birth midwives specifically. We also are one of the only states in the country with no freestanding birth centers. And we know that birth centers improve outcomes and increase patient satisfaction and help address rural maternal health care access. So expanding opportunities for that is super important. One way to do that is for the state to exempt birth centers from the certificate of need. Our biggest barrier to that is the medical lobby, specifically the Iowa Hospital Association and other organizations that have been trying to keep that from happening. The medical lobby was also a big barrier in expanding access to certified professional midwives for 30 years. We really need the medical lobby to start focusing more on what is proven to improve outcomes and being less focused on their own bottom line to actually improve outcomes for patients in our state, because we need all providers, we need all birth settings to be accessible to patients in Iowa. It's not one or the other. It's not that one is better than the other. It's that we need all of these options in a state that desperately needs services in so many different ways. So I'll stop there, and interested to hear what others have to share as well.
So yesterday, 2 days ago, I chatted with a lovely lady named Chico from Zimbabwe. And Chico, having identified a lack of available medical facilities in her country, just started building them. I don't know that the collective is going to go that far. That would be amazing. However, the work that we are focused on doing is advocacy work, education to make sure that people are aware that this issue is happening, to let them know what some opportunities are to make it better, policy, and then funding. And when I say funding, what I'm referring to is specifically scholarships for Black students to pursue work in the medical field. And what that looks like, it could be doula, it could be midwives, it could be OB-GYNs, it could be maternal nurses. We want to make sure that we are reducing barriers to access to those medical fields for people who want to pursue them, because we know it's a barrier and we know we can support in that way.
Yeah, another thing that so my focus is usually more on the end of community and community outreach. And what we've been really focusing on right now is health literacy. We know that with increased health literacy, there are generally better outcomes. However, the National Assessment of Adult Literature only found that only 12% of Americans in the United States actually have proficient health literacy, meaning that they have the ability to understand and navigate health information. So one of the things that we have been working on, and I've been collaborating with a lot of public health programs. A great one that I've worked with recently is focus on diabetes. While their primary focus is diabetes, they do expand into other aspects, including cancer as well as pregnant women. But we know that one of the most important aspects of this is supporting visual support, because 80% of individuals are actually visual learners. And we know that this works because studies have shown that visual learning can increase health literacy by 55%, particularly in underrepresented communities. And so one of the things that we have been making sure that we're doing is whenever we take on a project and we are doing a series of illustrations or an animation, that we are doing the research and making sure that we're understanding the community that we're reaching out to and we're trying to support, and that we're not ever making any assumptions about what issues they have and how we could be best supporting them.
And Asada, could you specifically just tell us about the lookbook
Yes.
that you mentioned as a very specific and I think great resource? Could you maybe talk a little bit about that?
Yes. So Johnson County Public Health, they were wanting to increase patients that were actually coming back for appointments. What was happening was with their women, infant, and children program, that especially immigrants, people would come for the first appointment and they really weren't interested in coming back. And so we found that one of the biggest issues that was happening at that point was that it was an issue of lack of diverse faces providing services. So these individuals did not feel very comfortable being open and sharing their situations. But we also found that there was a significant language barrier simply because these programs were offering primarily to a lot of immigrants. So what we ended up doing was creating a series of illustrations, which covered body changes, gestation, information about anatomy, basically a 101 for if you're pregnant, this is what's happening and this is what you can prepare for. And this is the terminology that is going to be used in the clinical setting. So even if you're not going to Johnson County Public Health, if you're going to urgent care or you're having to go to the emergency room, you have a little bit of education so that you're able to better advocate for yourself. So one of the nice things about this is because it was funded by the state of Iowa, it is free for any 501c3 that is working with women. Right now you have to contact me. So if you are working with women and you have a 501c3, you can email me at asata@legacybiostudios.com. And I will get in contact with you and make sure that you can get a copy of your lookbooks. And the lookbooks right now are translated from English to Spanish, French, and Swahili, simply because those were the languages of the immigrants in the Johnson County area.
Excellent. Dr. Radke, Dr. Bavers, do you have anything you'd like to add?
I can add that I think that the role of the healthcare system in addressing these challenges is really to improve both the quality of the care that is offered to perinatal individuals, as well as kind of the respectful approach to care. I really appreciated how Asada described earlier about really the legacy of historical racism in medicine and how that has caused a lot of distrust. And we need to both address this historical legitimate reasons for distrust in the healthcare system, as well as address the bias that we know still exists amongst healthcare providers. We do have some good evidence that when certain practices are standardized, where we know there really isn't a lot of room for medical decision making, that we should be really following a protocol. There's studies that when we do that, we reduce racial disparities in whatever outcome we're impacting. And I think to me that shows the bias that's still there, right? That prior to standardization of the care, that more vulnerable individuals were not receiving the same standard of care. That's kind of the space that I work in, is can I help healthcare providers through our programs improve their quality of care. But I think that the next frontier of that is, how do we take care of people, and how do we speak to people, and how do we make the healthcare environment a welcoming place? How do we recognize the types of births that people want to have that might be leading them to choose a home birth environment when maybe they aren't the best candidate for birth outside of the hospital because of individual risk factors? And how can we make a healthcare environment that might be safer, but not what the person wants? How can we make it meet people a little bit more where they're at? And so that's where I see the role of the healthcare system in addressing this, as well as we need to address areas where we just simply have workforce shortages. And I think we've spoken a bit about that, but how do we get specifically in our small communities enough providers? How do we make those communities good places for people to want to live and work? And also recruit diverse providers so that people are able to receive care from somebody that they can relate to. I think all of those are things that we need.
Mm-hmm. Yeah, as a rural Iowan, by birth and by choice now, I think just putting the resources out into the state to help our smaller, more rural communities continue to grow and be vibrant, to draw in those families, to draw in those healthcare resources, as well as working with our partners across the state in our more urban areas. I really see that there's a lot of opportunity for us to, continue to work together. But, making our rural communities more vibrant is, I think, a big part of this.
Absolutely. And so we do have a question from Tessa Mills, sorry, and this has to do with recruitment. Are there rural communities in Iowa investing entrepreneurship and business development to create attractive communities for potential new providers? Does anyone feel comfortable answering that question?
I
don't know that
know. Yeah, go ahead. I know that the state, I'm not sure if this went through, but I know as part of some of the apprenticeship policy that there, at last session, that there was some pieces around that with healthcare. I don't know that OB was part of it. I think nursing was. So I think that would be interesting to look into more with folks that are more on the workforce labor side in terms of how that's impacting healthcare recruitment in more rural communities. I know it was mentioned before about like the damage caps. We're expected to have a shortage of 150 obstetric physicians by 2030 in the state of Iowa, and research shows that damage caps do have zero impact on workforce recruitment. And so what's frustrating from a policy perspective is that we're not applying the solutions to actually address the real issue, right? And so we have this workforce issue, and we're kind of missing the mark on actually presenting solutions that will actually get to the issues of, in this case, provider workforce issues. And what I would like to see the conversation be around is like, how are we recruiting OBs? How are we recruiting certified nurse midwives? How are we recruiting folks that want to open small businesses as freestanding birth centers? It's not like a one and done, not a one provider approach. We need all different providers in different settings. And the current policies that have been presented aren't really getting to the actual issue.
Great. Well, we are out of time for today, and I do want to say a big thank you to our panelists and attendees for spending your afternoon with us. If you have further questions about this topic, you can start a conversation in the Whova app or reach out to our panelists directly there. You can also tune in to today's closing keynote session with Emmy Award winner and Iowa City native Harper Steele in conversation with features reporter Elijah Decius. Thank you all so much for being here, and I hope you have a great afternoon.
Thanks so much.
Thanks, everybody.